this process.
I was wondering. I had like a plan. Well, you but you know.
So things are good?
It's fine.
You got 80%. Okay. Oh, yeah. How you doing, man? I'm on. You have an idea what you're gonna do? You know the answer? Yeah. Well, you want to
Let me see. This comes up every couple of months. We don't do it often, but I think now.
Yeah. Just like I'm doing. And the tutorial.
She doesn't get it. All right.
Right. No, just. I don't walk you through it again.
Right. Let me follow up with radiology.
You can pay for unlimited. Like 2 months back. I think I remember you today where they will. I would. And they'll say, hey, this is a mistake.
She's like, pulling out water cup, she's like a drink. I'll talk to her. Yeah, I drink 3 of these, that's a lie. I think I'm already. So, I don't know what. Really, I don't know, it's not gonna be fun. The bowels kind of dilated, and they all think they're unavailable.
You sound like you could fall into golf very effectively.
I heard you were at the football game and you didn't visit us on Saturday.
I'm going to introduce Brad.
It was okay, that one.
Yeah.
Actually, they were.
Somebody did not go. Got it. So I stuck out. So yesterday morning, I stuck out. Absolutely. That work better for you? Okay.
Actually, she came, she probably used it.
Oh, all right. You fall into golf.
Right now in the lab.
My cider is high.
We should go ahead and, why don't we go ahead and get started? All right, thank you all for coming this morning. Today is our, get started now. Go ahead and get started now. Thank you all for coming to the first Dr. Bradley Rogers lectureship. I want to start by asking Dr. McGarren to come up and just introduce a little bit about Dr. Rogers and his impactful career, and then I'll introduce our speaker after that. Dr. McGarren.
Thank you. It is my. I want to make sure I can. Is this the thing that I? Okay, thank you. So yes, thank you. It is my honor and privilege to introduce Dr. Bradley Rogers, who this lectureship is named after, and this is the first one. So I'll give you a little bit of background about Dr. Rogers, Brad, and a little bit about history here, but we won't take too long. So Dr. Rogers, actually, it's not a stretch to say that he is one of the foundational stones and pillars in our field. When pediatric surgery was really getting going, getting boarded and everything, he was one of the people who was providing that foundation for it. He did his general and cardiothoracic surgery at Duke, and then at McGill, he did his pediatric surgery fellowship, and actually he's double boarded in both cardiothoracic and pediatric. He was at the University of Florida from 74 to 81 under Dr. Jim Talbert, his initial mentor. And I'll mention a couple of things there in a minute. Then he came here to UVA in 1981 and was here until 2017 when he retired after having built an unbelievable legacy in pediatric surgery, not only here, but nationally. Despite never running a fellowship here, he had the national presence and reputation to have been a very big impact in our field as time went on. One of the biggest things that he introduced early on was thoracoscopy to pediatric surgery. That was a seminal event. He helped work with the Stores company to, I think it was Stores at the time, to put the scopes together and the ports. And a lot of the ports we use today in pediatric surgery still harken back to ones that he helped design for chests back then. He, believe it or not, he ran the pediatric surgery match with his daughter on his dining room table from 1982 to 1990. And I was part of the first match that was not run on his table. And that was the first one that had a problem. So he was the chair of the American Academy of Pediatrics section on surgery. He's been the American Pediatric Surgery Association president. He won the Arnold Salzberg Mentorship Award in 2010, which is a huge award for mentorship in the AAP. And then he was the inaugural winner of the Robert E. Gross Award for Excellence in Research and Achievement in 2014, which was introduced for those who have made longstanding seminal contributions to pediatric surgery. And he was the first to win that because of the thoracoscopy early on in his career. He was included in a series of legacy interviews for APS's 50th anniversary, and I had the privilege of being able to perform that interview and log it later on. That was a wonderful afternoon to be able to spend together. After his retirement, we initiated the effort to establish the Brad Rogers Lectureship. I should mention that one of the initial seed contributions was made by Dr. Richard Siskon, who became a leader in our field. And then through all the donations and, that we were able to build up, it was taken, the funding was taken home by the Department of Surgery here when Reed Adams was chair. And, the funds simmer for a little while until we can finally do the talk, and that's what we're doing today. Just a couple of examples of some of the early thoracoscopy papers that Dr. Rogers wrote. And you see a couple of familiar names at the end as he tried to pull along some of his mentees here at the University of Virginia. These, despite never having run a fellowship, many people were inspired to go into pediatric surgery by Dr. Rogers. So a lot of people ask me why I went into it, and I said, well, I did a rotation with his service in 1983, and all I remember is that 3 days in, that's what I wanted to do. And thankfully, he's been an unbelievable friend, mentor, partner, about every relationship you can almost have over the years. And I've had an incredible career, largely due to his support and story. But if you look through these names, a lot of them have been leaders and still are leaders in our field. And subsequent to Robin, who's the last one who trained here while he was here, we've had 5 others match in pediatric surgery in the last 5 years. So the legacy continues of what he set up here at the University of Virginia. This is back in the heat of the battle, and this is probably about 2 or 3 years after I joined you. And we had a surgeon visiting us from Costa Rica at the time. And then as Brad moved into retirement, he is now spending wonderful time, and as our friend Tank Waldhausen says, every day is Saturday, with Martha Rogers, who is his wonderful partner, and helping guide their daughter Annie, who's now in sports management in Ohio University, and also his grandchildren from his son Brad and daughter Elizabeth as well. So it's wonderful that he's here, and again, it's our honor to be able to introduce this lecture and introduce
Dr. Rogers is going to make some comments after our grand round speaker. So thank you, Dr. McGarren, for that amazing introduction. So it's my distinct pleasure to welcome Dr. Peter Masiakos, Professor of Surgery at Harvard Medical School and Director of Pediatric Trauma Surgery at Mass General, as our visiting professor and grand round speaker today. So, Dr. Masiakos is a nationally and internationally recognized leader in pediatric trauma care, injury prevention, and health policy. A native of New York, he trained in general surgery at Boston Medical Center, where he was elected to AOA, and completed his pediatric surgery fellowship at the Hospital for Sick Children in Toronto. Over the last 2 decades, he has combined clinical excellence and a deep commitment to addressing social and structural determinants of childhood injury. He's built a remarkable career at the intersection of surgery, public health, and advocacy. He founded the Massachusetts General Hospital Trauma and Injury Prevention Program, and later co-founded and now co-directs the MGH Center for Gun Violence Prevention, one of the nation's leading academic programs addressing firearm injury as a public health crisis. His advocacy has directly informed legislation. Dr. Masiakos has helped to draft, testify for, and champion more than 11 Massachusetts injury prevention laws, including 2 landmark gun safety measures that have served as national models. His scholarship has provided the data underpinning these efforts with over 100 peer-reviewed publications and sustained NIH and foundation support aimed at reducing preventable injuries and deaths among children and adolescents. Beyond his legislative work, Dr. Masiakos has emerged as a trusted voice in organized medicine and policy, national policy circles. He has served on the American College of Surgeons Committee on Trauma, chaired the Legislative Advocacy Committee for the AAP section on surgery, and contributed to multiple amicus briefs and national position statements on child safety and firearm violence. His collaboration with former Surgeon General Dr. Richard Carmona helped catalyze recent Surgeon General attention to firearm injury as a public health emergency. Through his scholarship, mentorship, and tireless advocacy, Dr. Masiakos has demonstrated how surgeons can extend their impact beyond the operating room, improving not only the lives of individual patients, but also the safety and well-being of communities nationwide. Please join me in welcoming my friend, Dr. Peter Masiakos, to the University of Virginia.
I really didn't know I did all that. But in seriousness, 2 things. One is, it is a great honor to be the first named lecturer in your name. You have been a touchstone from afar. There's a few people that I can consider that. And the idea of disparities in healthcare delivery and outcomes is something that drove me from the beginning. And it's because of you. Despite being a thoracic surgeon and a cardiac surgeon and a pediatric surgeon, you're a visionary and brought the public into this discussion in trying to understand how we can do better for our patients. So thank you for this. Also, thank you for having me here. My son just graduated from UVA as an undergrad, so I'm an alum. $140,000 worth of and really Charlottesville is a second home over the last few years. And then lastly, I can't help but pause to remember Bob Bartlett. And we talked about an ECMO case this morning, and that whole field was established because of the vision of Bob Bartlett, who was a giant and a great man and a great physician. So one moment of silence for Bob, who passed away yesterday. Thanks. So getting to this talk, I have very little to claim in conflicts, but I will tell you that the 3 of us who have formed this sort of coalition of gun violence prevention advocates in Boston have history. And this is a very important consideration because it's personal for me. It was personal for me from the beginning as a trauma surgeon, but it became more personal in 2022 when my son was a freshman here. And I got the page saying that he was in lockdown. So that made it real. Kana Sachs, who is my co-director in the Center for Gun Violence Prevention, lost her cousin in Sandy Hook. And Gretchen had the same thing happen to her daughter in Michigan State. But these are the sensational stories we hear, and often are the overwhelming discussions in media circles. Before I get to why I do gun violence prevention now as a focus of my academic life, I want to sort of, for the residents, talk to you about pivoting and how I got there, because I didn't start there. I came back to MGH after training in Toronto at Sick Kids, and I was a chemist and a physicist. I did a PhD in biophysics and physiology before I went to medical school. I learned how to run magnets and build coils in Oxford, and then came back to Boston to be a tissue engineer, mitochondrial energeticist, tissue engineer. And I met Jeff Karp, who, if I had stayed with Jeff Karp, I would own 5 companies and not do any of this. But the reality is, it informed me about my love for science and outcomes and trying to build the idea of a tissue engineering lab. I worked with Jay Vacanti for a brief bit of time. And then I met this kid in a trauma call in my first day of call in the 3rd year of my career there. And Sean was an 8-year-old boy who was dropped off at a family friend's house in Plymouth to play hockey, and unbeknownst to the parents, he was put on an ATV and rode out into the sands in Plymouth, overturned the ATV, and he was pinned under it for 30 minutes. Was resuscitated and brought to me, but at that time he was brain dead. He persisted on life support for a couple of days and died. And a year later, his parents came to me and asked me to advocate for their kid because the laws that were existent were non-existent. They got a $100 fine paid by the person who put the kid on their bike. And so I went to the State House for the first time and walked the halls and advocated from what I knew, and I had to build rapport with the legislators, and it was really hard. But it was no different than building relationships that I had done in the past with my patients in an emergency room setting, having to take them to the operating room for the first time. So fast forward 4 years, the law was passed. 2 sessions, a couple of failures, a couple of instigators that didn't want this to happen. And the law was passed. My son went, and he seemed thrilled at the time. But it was the first instance that I felt empowered to do something that I'd never done before, changing laws that would impact trauma care before the trauma happened. In the ensuing years, we passed a few driving laws together with the legislators who didn't believe I was a trauma surgeon going up to the State House to do policy work because we never went. And it became easy. Just yesterday, I got a call from the former speaker to see how I was doing. And the speaker's office was an open door for me. And I would encourage people, and I know Richmond's an hour and a half away, but the politics might be a little bit different than the communist state of Massachusetts. but the idea of relationship building with your legislators is important because they want to hear the information that you have that drives their policy. And oftentimes they don't know that. We saw outcomes. I studied the laws and showed decreases in deaths, injuries, and sustainable changes in impact for these kids who had now had restrictions. One of them was the junior operator law, which has become nationalized now. Everywhere in the country, the parents of a kid have to sit in a classroom and listen to a video or watch a slide deck, which I had to do as well. It was my slide deck. I was sitting in the classroom to watch about my kid who's learning how to drive. And the number of deaths and injuries in kids precipitously fell after this graduated driver's opportunity. We saw it in Massachusetts. We had a concussion law that was established. But what I learned in the process of all of this is that we are easily building coalitions within the medical community. The American College of Surgeons came on board, the AAP came on board for all of these laws. In fact, there are white papers from all of these organizations. And getting the hospitals in Massachusetts to agree that this is important was easy. But what the politicians inform me is that it's beyond just hospitals, that you have to have these conversations. You need to build coalitions. And for example, in the ATV laws, the motorcyclists and the Sierra Club and the land trust conservationists came along and said, we don't want ATVs on our land because it disrupts the environment. So it became a very interesting discussion that I learned quite quickly to establish out-of-box coalition building. And I took that to heart and built this approach to all of these laws that we made that were essentially established on the basis of data. You have to define the law, you have to define what your problem is, you have to identify the risk factors for it. That's the public health approach to any injury prevention law. You have to educate the public, you have to enforce the laws, and you have to reinforce the laws. Because if you don't, people forget them. And if you don't enforce them with some kind of imposed fine, people don't listen. And so the process is far beyond just a public health approach to injury prevention, but it does involve legislation and enforcement. And the police departments, the state and local police departments have been implicit in this. When a surgeon talks to a police officer, many things can happen because both of the interests are the same in preventing injury. This is one sticking point. We do not have a primary seatbelt law in Massachusetts. I've been working on a primary seatbelt law for the last 20 years and it ain't budging. Anybody hazard to guess why? Byron Rushing told me why. So I was knocking on everybody's door. Byron Rushing was the representative from Jamaica Plain, which is predominantly at the time Black and brown community. And I went into him and said, why are you holding up the law? It was being held up in the Black and Latin caucus. They wouldn't pass it. And he looked at me and he put his feet on the table and he said, why do you people come into my office to tell me what my people need? Why don't you ask me what my people need? And I paused for a minute and he said, the reason that it's never going to pass in Massachusetts is because it's another example of where people can be pulled over for driving while Black or brown. A revelation to me. And I stopped. And I could understand why he was saying, we don't involve the subject matter experts in many of the things we do, which is going to come back in the discussion of the gun violence work that I've been doing. Now, the subject matter experts are your community. And we do a poor-ish effort to bring them to the table to have these discussions with us. And I find over the years that that has been the most important, overwhelmingly important issue of trying to get these laws done. December 12th was the turning point. I, at that time, was working only on motor vehicle regulations and some other small laws in Massachusetts that would prevent fire injuries or window falls. And so Sandy Hook put a pause on that for a minute. And three of us sat in a room to talk about what we can do about gun violence. And we were hearing things like this: gun deaths in America are a fact of life. Nothing's going to change. We have to take guns away. And all of these narratives are wrong. In my mind, from the beginning, they were wrong. And so I approached gun violence like I approached the other injury prevention modalities that I was advocating for and trying to understand and defining the problem. It's a hard problem to understand completely. But if I were to say to you that it is no different in trying to understand the language and the right words to use to change the culture of why people shoot each other or themselves, is an important consideration in the way that I approach this. My father used to throw me in the back of a station wagon when I was 7 and drive us from New York City to the Jersey shore while smoking in the car. And so culture has changed for many things. Lung cancer has been impacted by the fact that we've reduced smoking rates by about 60%. So it's not overcomable. But if we have the data that are presented in the wrong way, it is a hard thing to overcome. This is what people perceive gun violence to be. 5 buckets, all equally related. The ones that you see in the media are the mass shootings and the police-involved shootings and the homicides. But this is the reality of gun violence in the United States. The sensational don't hold water, but they are as important as the other things. Deaths are what we count, but injuries are not counted. This is the CDC website for the number of injuries that happen in the United States from gun fire, penetrating trauma. But if you look at the confidence intervals, the data are junk. This is what our government knows about gun violence injuries. We do know that gun violence in kids is the #1 cause of death in now children under the age of 20. And that slide should have been the last slide. So if we start with the wrong narratives, how are we going to change people's cultural approach to this problem? And defining the right narratives was imperative. Let's look at a few things that our own society tells us about tourniquets. Tourniquets save lives, certainly do if applied right, and many of us in the room have seen them not applied right. But there's a big push that started in 2013 with the Hartford Consensus on the heels of Sandy Hook in trying to build a process by which people can be informed about gun violence using tourniquet applications. Stop the Bleed is very successful. Stop the Bleed is predicated on combat tourniquet use and now transforming it into a civilian application. No doubt that it saves people in certain consequences, but is back to school training important for our kids to learn? There are high schools now across the United States that mandate tourniquet training to graduate. And there are some middle schools that are trying to impose that in their curriculum. I argue that that's traumatic and probably not the right approach to tourniquet use. So we studied it. We looked at the Sparks data in New York State, and looked at all of the penetrating traumas over 10 years and found that the ones that are tourniquetable amount to about 2%. Gunshot wounds to the extremities happen infrequently, but when they do, 2% of the time you have to apply a tourniquet. These are the patients that underwent surgery. Armed guards at school are the answer. So I'm going to touch on a few controversial points here. I'm going to sort of weave around them a bit, but I just want to prove the point of using the language right and seeing if we can figure out if this is the right approach. And I'm not saying it isn't the right approach, but I'm wondering if it is the right approach. Does hardening schools stop mass shootings in schools? Again, going back to the idea that mass shootings are the thing that we have to focus on. The $3.1 billion industry now. And let's take a look at arming schools. So if we placed 5 guards per school, in my town there are 3 in high school, you'd need 650,000 armed officers at a school to protect all of the elementary, secondary schools. That's not counting theaters, that's not counting churches, that's not counting other universities. And if you take the back of the envelope calculation, the armed forces active duty personnel amount to 481,000. So is that a practical approach to this problem? I would argue that it isn't. And how good would we be in this situation? So we're studying this as well. Right about a month ago, there was a shooting outside of Mass General in which a person acquired the gun of a police officer who was on detail. And the police officers fired 12 shots and missed him. He ended up shooting himself in the foot. That was his only injury, despite the fact that he was armed. And so we asked the police department in Boston to see if we can simulate these activities to see the civilian gun owners can do as well as police do. Now, if you think about missing 12 shots in close range, it's hard to do. And Amy Kaplan, where are you? She's the best shot in Boston. And I'll go to that in a minute. Amy is one of the medical students who worked with us in Boston for a couple of years. And we took this idea to an MIT simulator where you're exposed to scenarios that you have to respond to. You're holding a 9mm handgun, and a person dressed in a hoodie is entering a classroom, and you have to make a decision about shooting them. The police use this in de-escalation approaches and are as good as 30%. They can hit the right target 30% of the time. In civilian hands, it's nowhere near, except in Amy's hand. Amy hit the target every time. But the reality is, can we test this? And we're now doing some simulations with civilians and with law enforcement to see whether they can distinguish between the good guy and the bad guy in the situations that are built for the purposes of understanding this. The other thing we hear about is a gun in the home makes it safer. In some cases, it may, but the overwhelming independent risk factors suggest that it is not a safer environment. Suicide is up across all ages. 50% of the suicides that are now happening in the United States are handgun related, and equal essentially between approaching male and female. But more importantly, kids are killing themselves more than we do. And this phenomenon of self-inflicted wounds and suicide is important because in medical school, I didn't learn this as an impulsive act. I learned this as a plan. And you would ask about suicidal ideation and eliminate that risk. But the reality in kids we're finding now is from the time of thought to the time of action is 10 minutes. And if there's a gun in the home, 90% of the time you find that you do it, you're dead. If you take a pill or you suffocate yourself, 80% of the time you survive and you don't try again. So who are we approaching the most in this bucket? Are the vets. There are about 20 to 30 suicides by gun a day in the veteran population across the United States. And the discussion of access to lethal means isn't happening with that population. The other thing that we're looking at is intimate partner violence. I bring your attention to the last bullet point here. Recent data shows that we have showed that it's the #1 cause of maternal death in the United States now, exceeding all other causes of maternal death. And all of this is interpersonal violence related. 4.6 million children live in homes with unlocked and loaded guns. Most of them happen to be in the bedside nightstand. So how do we change that thinking? We're not going to take away 400 million guns. It's not appropriate to even think about it. It's not appropriate to say it. So how do we do it? In 2018, we formed the Gun Violence Prevention Center at MGH, and it's predicated on 3 pillars. Research to get those data that we need to inform our government and our patients. Education, which informs the medical providers about how to have these conversations that everybody wants to have, but is afraid to have because they don't know the words to have them. Just like I learned how to talk about HIV when I was going to medical school. That was a hard conversation to have in the clinic. How do you talk about your gun access in a home in which the child is under duress or vet is in despair? How do you have those conversations? And then finally, community. And community centers all of this because these are the subject matter experts. The veterans are the subject matter experts. The veteran service officers who provide social services to them are the subject matter experts. And when we started the work, we were asked, why are you doing this in Boston? It's safe. It's the safest city and the safest state in the country when it comes to violence and gun violence. It's the best. We're the best. Hawaii sometimes beats us, but that's because of the weather. But there was a publication that came out in 2018, which showed that if every state had the laws that Massachusetts had, we would save 27,000 lives a year. And we were sitting in a room listening to this, and the people who wrote the article, the governor, the Department of Public Health chair, were in the room touting the successes of Massachusetts based on the merits of the law. And somebody from the back of the room stood up and said, "That's not my Boston." So I went to talk to her after, and she goes, "Yeah, I live in Dorchester. There are gunshots that go off every day. I'm not safe. Maybe they're not hitting people as much as they used to in the 90s when I trained at Boston City Hospital, but they're still impacting my life." And that woman was introduced to me later by Billy Evans, who was the commissioner of Boston's police department, who was the guy that is portrayed by Mark Wahlberg in Patriot Day, the Boston Marathon bombing. He claims Billy, who they call Mouse, is not Mark Wahlberg. But he's a great guy, and he knew the people in the community because he was an awesome patrolman, worked his way through the ranks to become commissioner of the Boston Police Department, knowing the community. And he introduced me to Clementina Sherry. Clementina Sherry is the founder and CEO of the Louis D. Brown Peace Institute in Boston, one of the most impressive violence intervention programs in the community, providing social services to the people who are survivors of gun violence. Her son was killed in 1993 in a crossfire incident going to a peace march. And she formed this institute to provide a resource that was absent in Boston, in Dorchester, in her backyard. And what she talked to me about was the fact that although we have about 160 homicides around Massachusetts every year, there are about 8,000 survivors and families of the kids who are killed, mostly, and the older folks that commit suicide. If you extrapolate that nationally, there's 1 million people a year that are affected by a gunshot that injures somebody. And the other thing she talked to us about was the idea that it's not about just the physical trauma. She said that gunshots happen at night, and we called Boston Police, and Billy Evans gave us the data and said that the data suggests that there are about 2,000 shots fired called in 911 calls in Boston every year. Dorchester, Mattapan, Roxbury. That's where all the shots are fired. And they happen between 10 o'clock at night and 2 o'clock in the morning. And the response of the Boston Police Department is they go to the scene with geocodes based on the call. Police, fire, and ambulance respond. There are lights, sirens, and knocking on doors, and the kids don't sleep. They don't go to school the next day because they don't sleep, and they're milling around and eating their families out of house and home. So these are the social consequences of a shot fired. We found it's 2 times likely to occur at night during the day, and nighttime shots are more impressive. It happens everywhere. We got the data from Baltimore, we got the data from DC, Philadelphia, Portland, Oregon. And all of these shots fired events cluster in neighborhoods of color. So if you're going to impact interpersonal homicide, we got to start sorting out what we have to do about sleep hygiene and maybe responses to the shots fired that don't hit people. The Boston Police Department has agreed not to approach these in the middle of the night with lights and sirens because there's no traffic. And they go to the scene, geocode scene, and they're there and they're conscious about the environment. And they do their investigation. Most of the time, you do not find the victim. So 2,000 times a year, it used to be that people are awoken in the middle of the night. We're going to look and see how much less that happens now. The other thing that we've seen is the consequences of a gunshot wound on the families of the victim. And we've done 2 studies now. One is coming out in about a month that demonstrate that the utilization of healthcare services of the non-injured go up. In fact, for fathers of injured kids or deceased kids, there's a 138-fold increase in access to mental health care. We're seeing that in siblings now, and we have just new data to suggest that insurance churn, loss of insurance of families whose parent is killed or commits suicide, eliminates healthcare access to those families as well. So the social consequences of a shot, either hit or miss, are significant. And what we are modeling our work now is that the deaths are the tip of the iceberg, and that's what everybody talks about. The injuries may be a little bit better, and these numbers are reflective of Massachusetts, of Boston, actually. The shots fired, as you see, and we're working on the other issues of gun-related threat and individual fear, and how people can do better at social service applications for the purposes of getting these families support who need them. But we couldn't do this alone. We brought in the community to tell us and inform us how to do this. And we can't do this in hospitals because the families of injured or dead kids don't want to spend time in the hospital. So we approached Emerson College, which is a university down the street from Mass General that focuses on media and journalism. And we asked them to provide a resource to do coursework at Emerson College, where we'd bring community into the school in collaboration with the students and with healthcare providers. And 4 years ago, we established this program called Transforming the Narratives of Gun Violence. And this short video will hopefully play. It tells you about. It's just taking time. So this will give you a little bit of background about what we do. Or maybe not. No volume. I need volume.
That's not our Boston.
That's not our Boston.
Esto no es mi Boston.
Este não é meu Boston.
That's not my Boston. Se pa Boston conmigo. That's not my Boston.
Our children don't deserve to be hit. They don't deserve to be shot down.
For every person shot by a firearm, at least 10 immediate family members are impacted. Repeated gun violence and the systems that perpetuate it lead to trauma for individuals, families, and entire communities.
Child dies in the emergency room from a gun wound and nothing happens.
Coming to the hospital and somebody making a cold remark like, which one are you here for? Because there were multiple people who were shot that night.
To make that John Doe or unknown male a person, right?
How is it that journalists are covering these stories and are choosing these sensationalist headlines instead of in-depth reporting? How is it that policymakers are making decisions about how to allocate funding without really understanding the voices and the stories of the communities whose policies are affected directly by them?
We are a community
of storytellers,
lifting up the voices
of those most impacted by
gun violence in our city.
Every day in Boston, neighbors are coming together to support one another.
For individuals like me who were formerly incarcerated, we do commit to the uphill journey of building a new life and paving new pathways for those who will come after.
Transforming Narratives of Gun Violence is a collaboration between the Engagement Lab at Emerson College, the Center for Gun Violence Prevention at Mass General Hospital, and the Louis D. Brown Peace Institute. Through co-created documentary, interactive and immersive media, games, journalism, theater, and more, we are inspiring solutions and interrupting cycles of violence by focusing on what people have, not what they lack.
Social Impact Studios are semester-long experiences at Emerson, where students and faculty work alongside community members to understand the roots and impacts of gun violence narratives in the media so that they can create new ones.
The initiative is guided by a collaborative leadership team, including members of community organizations, doctors, elected officials, faculty, and students. The leadership team guides, amplifies, and distributes the narratives we make together.
To healing, to peace, to sustainability. What are we transforming to a better community?
I would argue that that is the secret sauce in trying to change what's happening to people who are in despair or hopeless. The vets, trying to get the narrative changed so that it affects them more importantly than the laws that are passed that need to make stigmas of certain things, right? So it started with one class. We've been doing it for 4 years now. At Boston University, just picked this up and we moved it to Boston University where we have access to all of the colleges there. If people have read this was my perspective piece that sort of laid the framework for this class. I wrote it in the New England Journal of Medicine. It was a perspective piece. It's the most cited thing I've ever written about my delivery of bad news to parents. The families and the kids in the classroom took it and made a documentary film out of it.
It's a room. It's got a chair in it, it's got walls in it, it's got art in it, and it's designed to isolate, takes the family away from everything.
I couldn't see or hear anything. I don't know how long I sat in this room, but it was the most cold, unwelcoming room I've ever been in my life.
I'm gonna tell you my story before someone else tries to tell it. Does that make sense? And when you tell it, you heal, right? When you tell it and it's authentic and it's true, you heal.
We just need a safe and neutral space for that to happen without judgment. And that's what Santry Wordplay did for me.
In order to build strength or build anything that you want, you need tools.
We all have what's within us, the innate ability. We all have what it is that we need to heal.
So 12 studios later, 103 students, 44 community partners, 2 graduates from the community who got 4 credits every class they took, now have a bachelor's degree. 6 publications, 8 products, and it's being shown in film festivals, universities, police departments, state, federal courthouses, hospitals, White House. The White House had a viewing of it about a year ago. Medical conferences and jails. So the message is going from the community back to the community. And we'll study the impact. We'll study whether or not these products do have an outcome. Clementina, in her visionary way, said to me, so now what are we going to do? So we have the video, we have the thought of reproducing a room. And she goes, why don't we build a room? That's the place where all of the social healing starts. The resources start. The VIAP people can use the room. We can get information to people about how to bury their child, which many of these families leave a hospital with not knowing how to do. And that's the room that we used in the emergency room. Everybody's in that room. And Clementina remembered the orange chairs in the room that her son, the doctor, talked to her about her son. It was the same hospital as I was a resident. I remember the orange chairs too. She goes, what about asking the administration at MGH to redo the room? Now, the easiest thing for hospital administrators to say is no. And then you got to pick the colors that are on the color swatch. And I asked and nobody said no. And we revealed the room in August, in this past August. Social workers are using the room. The mural was painted by the community survivors. The BIAP folks used the room, the nurses used the room for a break in the emergency department. So it became a room that, instead of being a storage space used for breaking bad news, has become a place where people can start their healing process, which I'm very proud of. But how do you get this information to students? And I'm going to wrap this up really fast. When we don't have these conversations in the clinic, compared to alcohol, tobacco, firearms are not discussed in the intakes of any social history. Very rarely. The blue is the time guns are mentioned in a history, in a medical record. We parsed 80,000 medical records, and that's what the distribution is. We don't not ask vasculopaths if they smoke. Should we be asking people in duress whether there's a gun in the house, and should we secure it? And then we took it one step further, and Madhu, you were there when we did this study. One of your pediatrics residents actually came up with this idea to look at the kids that are coming into the emergency room with suicidal, homicidal ideation. In 1 year, we had 100 kids that came in. 25% of them were sent home without being asked if there's a gun in the home. So what has happened? It's expanded to all of the practices because it's not just isolated to kids. We put residents in a room. We came up with some archetypes and scenarios to sim this conversation. And we started providing 1 hour of sim training for every incoming resident at Mass General in 2020. We've done it by Zoom. We've done it in person. We've trained over 2,000 people. Amy did some work with school nurses in New Jersey, amongst other places, to train them about having these conversations with kids who are in despair about whether there's a gun in the home. Nobody would argue that removing a gun from the home of a kid or anybody who is under duress is the wrong thing to do. And we've seen a 5-fold increase in documentation within a year. It's now up to 50%. So what can we do to scale it? We've partnered with the New England Journal of Medicine recently to establish a virtual-based SIM program.
As clinicians, we know that focusing on prevention is essential to providing good health care. We need to take that same approach with preventing firearm-related injuries. This topic is directly relevant to health. More than half of deaths from firearms are due to suicide. A child might find an unlocked and loaded gun in a parent's nightstand. An older adult with cognitive impairment might injure themselves or a loved one. We shouldn't shy away from these topics. They're important to our patients' health. But many of us don't know how to have conversations about firearm safety effectively. That's why the New England Journal of Medicine, with its partners at the MGH Gun Violence Prevention Center and Cincinnati Children's Hospital Medical Center, are offering this free training program. In this program, you will schedule a one-on-one training session to build your skills counseling patients about firearm safety. During your session, you will practice asking patients about secure firearm storage and providing advice to improve safety. You'll encounter virtual patient avatars.
Yes, but we keep it loaded.
Controlled by live facilitators who will provide real-time feedback to help you improve. To get the most out of this session, you can review some background materials, which are available on this website. You choose how you like to learn. Watch a short video.
The lock that goes around the trigger here.
Oftentimes people look at the individual factors and
read a review article, listen to podcasts, answer multiple choice questions, or a combination. Focus on what to ask and what advice to provide regarding firearm storage to maximize safety. Then, practice with simulated patient conversations during your avatar-based training with live feedback. Visit our website to learn more.
So we are at 10 schools now. We've trained 850 students. And we are lined up 5 schools for 2026. There's no difference between the live sim and the virtual reality sim. The students, the learners love it. We're going to study distribution of 2-to-1 learner to educator to see whether or not we can scale this faster and try to get it to more places at a lower cost. I just went to a veteran service officers meeting in Leominster on Monday, where we trained 250 veteran services to have these conversations with their vets. So everybody feels the need to ask. Everybody's afraid to ask because the patients may get offended or may not come back, but they don't get offended and they do come back. So we're moving on. couple laws that have happened since gun violence started in my life are red flag law in Massachusetts and an act modernizing firearm laws in Massachusetts, which incorporates the medical provider and the ability to report to the state for temporary removal of gun from a person who's under duress, but mostly it's voluntary in Massachusetts. The Bipartisan Safer Communities Act in Washington allocated about $3 billion to school safety in the form of mental health care and also remediation projects. The ERPO law in Massachusetts, as I said, included some social work and physicians. The Surgeon General's report, we advocated for, and Dr. Murthy produced it in 2024. As you can see, the pyramid is reminiscent of what we talked about earlier in our pyramid. This is a nicer pyramid. And then what happened? Surgeon General's office, the report was washed from the site. The WISCAR's data is gone. But we have 20 people now in our group that are looking to continue the work despite the impact that the government has had on making it go away. The kid that was in the room in 2010 has grown up. Jake Auchincloss is a rep from Massachusetts. Hugh Auchincloss was his dad, is his dad. He was a transplant surgeon, NIH-funded transplant surgeon. Jake is his son. My son is in Washington learning to be a constitutional lawyer. So he may have seen something in that room. But I think that the future is in the young. And I look at the back of the room and count on you to take the torch and go with it. And don't be afraid to pivot. You find something you love, just do it. And all of the rest falls into place with a little bit of hard work. So thank you very much for having me today. I hope this was good enough. And I did take another road. The hardest conversation I had was with Andy Warshaw when I told him I'm turning in 2 NIH grants so that I can do this work. And he said, go for it. So here I am. Thank you very much for having me. And
we have time for some questions, and we'll ask Dr. Rogers to come up and give some comments. Questions from the audience?
Okay. Peter, at Mass General, there was a time when EPIC had these questions on gun violence, and then they disappeared from the social history.
Yeah.
Are they back?
Yeah, so we were advised by the social workers that putting the questions in the medical record predisposes the person who might be gang related to loss of social services. In Massachusetts, if you're associated with gang violence, you are not afforded the social services that come with that issue. That's changed, so they're back. So the governor has taken away that regulation, and now regardless of who you are, regardless of what you do, regardless of your background, if you're a bad guy or a good guy, and you're hurt or your family's hurt, you don't lose services. So it's back in Epic.
That's great, thank you.
Yeah, the nurses actually got it back.
Dr. Masiakos, that's awesome. Really so glad you could come down and give the presentation. In your advocacy work, how do you adjust your message to different political parties? Do you talk differently to Democratic representatives versus Republican representatives, knowing that they have different constituents that they may be beholden to?
Yeah, so that's a great question. In Massachusetts, we don't have parties. We have one party. It's a Democratic Party. There's 4 Republican congressmen in Massachusetts, but they represent the western part of the state. And we had this issue in the ATV law from the beginning. These are my constituents. They ride ATVs. You can't legislate common sense. There are 15 dealerships in Massachusetts that are in my riding. But then you show them the data of injury and how much money it saves. And the one head injury from an ATV rollover, non-death, was calculated to be $3.1 million per injury amortized over the life of the child. So you hit them with the pocket. As soon as you can show them. Now, one of the factors that's important in the discussion of gun violence, I do not talk about taking away guns with either party. They can talk about it all they want. That's not my job, right? My job is to inform them about what they can do to help get health care and help the families. The cost to care for gunshots in the United States, death and injuries, exceed the budget for the Department of Education. That's what they need to hear, right? So how do you change culture? You talk about the things that are culturally sensitive. Forget about the amendments. Forget about taking guns away from people. Let them decide that they don't want to smoke anymore, right? And that's what happened with the Surgeon General's report about smoking.
Make a quick comment too about your program with teaching students and residents about screening around gun violence. We're actually I'm the clerkship director here at UVA, and we're in conversations to join that. I know Dr. Andrews and Chana Sachs have talked to them for a long time, so I'm hoping we'll be able to.
You're on the list. You're the next one of the next 5.
Yeah. Now Dr. Andrews is running for Senate, so I think.
So she was part of the initial program. I don't want to take up too much time. We can talk after, but she was imperative that we had to get this out, and every town funded it to start, and we have $2 million of work to get it out, money to get it out. So it's free now.
Dr. Rogers, can I ask you to come with comments?
Well, Peter, thank you for a spectacular inaugural Rogers lectureship. That was something, and I think for the residents and students in this room, you see that our job goes far beyond the operating room and goes to state legislature, national legislature, wherever, to pursue what the causes of our problems are, the kids' problems. In my era, it was the three-wheel ATV. And it was pretty easy to show the mortality and the injury rate on the three-wheeled ATV. And we managed to get it pretty much eliminated. At least you can't sell one anymore. You can sell a used one. And also, I think what you've shown the young people here is that you have to tiptoe around the politics. It seems amazing, but in my era, you couldn't collect gun data. You couldn't get a grant to study gun data in children. Second Amendment people wouldn't allow that to happen. And now things have loosened up and you can get some data, but you can't do any of this without data and without being able to show people what it costs to bang your head on an ATV and survive, and what it costs to be shot in the leg rather than the heart. I just want to say I'm very honored, of course, that this lectureship has been established, and I thank Jean for shepherding that, Dr. Goshen for shepherding that through. But I recognize fully that this is not Bradley Rogers' lectureship, that surgery, and I think particularly pediatric surgery, is a team effort. And we've got people in the OR technicians, OR nurses. We've got nurses that work with us on the floor. We've got secretaries. We've got a whole cadre of people that we absolutely rely on to get our patients taken care of. And all those people need to be treated with respect and dignity that they're extremely important to our practice and to the successful outcome. I couldn't help but think I'm supported up here by a cane now. And this cane was given to me by a patient that I took care of. This was given to me in 1987. And this young man had been hurled out of a car speeding up 29 North by his drunken or semi-drunken colleagues and had broken every bone in his body, I think, in addition to his liver and spleen and probably several other organs that I don't remember. And he was in the hospital for months and recovered and went into rehab. And they had him walking with a cane. And when he finished his rehab, he came up to me and said, Dr. Rogers, I want you to have this cane. And I looked at it and I said, well, thanks, Jared, but I don't need a cane. And you realize, I've never even thought for a moment I'd ever use a cane, but I hung it on my door in the office. And when I retired, whenever 25 years later, there was the cane. So I thought, well, I better take that with me now. And between my cane and my wife, I can stay upright. We're blessed with the patients that we care for and the families we get to know. I've practiced for 35 years and was blessed with every day I practiced. It's a wonderful honor to be able to do that. And I thank you. Terrific start to the Rogers Lectureship, and many of you who contributed to perpetuate the Rogers Lectureship. I thank you and appreciate it. Great start.
Your research on the